that's been widely reported, but not widely explained, other than just its hormones, is the degree to which women experience a flare of their symptoms every month with their cycle. Why would having a period make your long COVID worse? Well, in this film, I talked to world-leading MCAS expert Dr. Tania Dempsey about why women suffer more frequently than men and why periods get so much worse than they were already. So could you tell me which chronic illnesses do you tend to see that disproportionately affect women?
Yeah, so I would say that autoimmunity in general, immune dysfunction, um, issues regarding like, well, obviously there's some things that only can affect women, like endometriosis, migraines. Well, migraines can affect both, obviously, but definitely a higher prevalence in women. Interstitial cystitis can be seen in men, but much more common in women. I would say that those are all illnesses that can be attributed to mast cell activation syndrome. So are there any that are not? Fibromyalgia is another one, seems to be a higher prevalence in women. Again, I can say that that's probably mast cell driven. So it's interesting. The more I talk about it, the more I'm like, well, really the chronic illness is really mast cell activation syndrome.
Yeah, how commonly accepted is the science for why women might be affected with conditions like these? Do 80% of doctors, are they able to answer the question about why, or is the medical community still scratching their head a bit?
Yeah, I think they're scratching their head. I think that they've accepted that hormones are playing a role. I think about, for instance, endometriosis, which is which is known to be autoimmune in nature, is known to be caused by high estrogen levels. It's basically like the buildup of tissue that is in areas outside of the uterus. So instead of like the uterus building up, you can get tissue, you can get endometriosis on the ovaries, outside the uterus, sticking to the intestines. It could be very, very painful. It's a big cause of infertility. But I think about that, and a lot of doctors see it as, oh, okay, it's because there's a lot of estrogen or there's some autoimmune process going on. So we're going to go in and we're going to just like cut the endometriosis out of the patient because that's going to really solve the problem. Let's just cut it all out. And obviously they don't get to the root cause. So I think it's hard. So I think that they're like at the tip of the iceberg. And if they just went one step further and understood why the estrogen may be affecting women in a certain way, then they may be able to see it. But you can't see what you don't know. So I think that, look, I'm an optimist. I would like to think that the medical community wants to understand things. They just don't know where to look. And they've been fed certain information in their medical training. And a lot of that becomes dogma. It's hard for some doctors to see or learn new things. But I think that unfortunately, or fortunately, however you want to look at it, long COVID may change that. The more people that doctors see that are chronically ill, the more they have to wake up and say, well, how are we going to help these patients? So I think it's unfortunate, but maybe it will be revolutionary too.
So when you compare the men that you sort of see as patients with long COVID and the women that you see as patients with long COVID, how did their presentations differ, if at all?
There are a lot of similarities for sure. And so that's why I want to be clear that it's not that women are sicker necessarily. I've seen plenty of men with long COVID, with ME/CFS, myalgic encephalomyelitis, myelopathy, chronic fatigue syndrome. It's like a mouthful, ME/CFS, or anything like that, right? I've certainly seen men who are really sick, but I think that some of the women have that extra layer of the hormonal stuff that they deal with, particularly if they're premenopausal, so perimenopausal or puberty. There are times in a woman's life when the hormones are shifting more than at other times. So that's puberty, that's pregnancy, and that's menopause. And it seems that during those times, a wider shift of hormones, more likely to be things to go wrong. And that may be the time when the mast cells get more activated. It may be a time when the immune system related to the mast cell, but not only just the mast cell, may be activated in a negative way. And so women who have these chronic illnesses, not only are they dealing with the rest of the stuff, right? But they're dealing with the hormonal piece that could lead to like things that affect them every month, or issues with infertility, issues with, I mean, there's so many women's issues that can develop that men obviously don't deal with. Now, men have their own slew of things that they have to worry about, though. Yeah.
So could you tell me, I mean, one of the things that we seem to hear about a lot in the long COVID community is how women's symptoms flare up, every single month in sync with their periods when they have them. Could you tell me about what kind of symptoms flare at those times and what might be the mechanism behind that?
I'll mention that every woman is different. And there are women who are more likely to flare earlier in the month, and there are women who are more likely to flare after ovulation in the second half of the month. There's some patients who will flare during the period, but they may not flare before. So, I think the reality is that the mast cells are so heterogeneous. They're so different, even within one person's body, how the mast cells work, what mediators they produce are going to be different. And then certainly between people, it's going to be even more different. So that's the point, is that I can't say that it's more likely to always be like this, but I would say that in general, a lot of women, when the estrogen levels tend to start to go up. So I think about it like this. Let me step back. Mast cells are reading changes in the environment. So they can read changes in temperature, barometric pressure, hormone changes. So for some people, some women, it's the estrogen going down that the mast cells have a problem with. Like, oh, where did the estrogen go? Or it's, oh, wow, there's so much estrogen now. And mast cells have receptors for lots of things on their surface. That's how they read the environment. So they have receptors for estrogen, progesterone, testosterone. They have receptors for histamine and like over 1,000 receptors, over 1,000 mediators. So the estrogens can bind into this receptor on the mast cell surface and send a signal to the mast cell, bad, do something, and then the mast cell can degranulate, do a whole host of other things that is doing, and it can release these mediators. Now, for some people, the mediator may be histamine, and so their symptoms may be more histamine related. For some people, histamine intolerance in the gut and their digestion and their food tolerance may be affected during that time of the month, even though you can say that the estrogen, maybe not every cell in the body is seeing all that estrogen. The mast cells are seeing it, and the mast cells, for instance, in the uterus, which are seeing a lot of the estrogen, are sort of talking to the other mast cells. There's communication going on. So they could have symptoms in their GI tract, even though whatever's going on is really in their uterus. They may be more itching. They may have more cognitive issues during that time of the month. So the symptoms can be very varied. And then, once for a lot of women, once this is sort of, they have this period of time they're dealing with this, they can then often, when the shift of the estrogen comes again, so it goes down during the menses, then they may get a relief. It may be worse. It's hard to know, but they may have relief for a little bit. A lot of women patients will say they just can't wait until after, for a few days, they get this reprieve. There's no hormones. The mast cells are not being affected. I don't know if that answered your question, but that's sort of why what I think is going on. And it makes perfect sense to me, because there are so many mast cells in the uterus. There are so many mast cells in the ovaries. there's so many mast cells in these different organs. And so if there's a place where there's just a lot of hormones, then the mast cells are going to react to them and then again communicate to the other mast cells elsewhere.
How well accepted is mast cell activation generally across the medical community? And my sense is that, you know, this is not widely understood. It's not widely thought about. Is it fair to say that? And is the situation changing much?
Right. I think that the long COVID maybe is, awakening, this a little bit and maybe, making it more acceptable. But in general, it's not well known in the general medical community. It's just one of those things that if they've heard of it, they think of it as a rare condition. Not understanding, a lot of people confuse mastocytosis with mast cell activation syndrome. And mastocytosis is very rare, and mast cell activation syndrome is very common. But a lot of doctors are not taught. I mean, I think we probably learned about mast cells for maybe 5 minutes in medical school, if that. So it's not, really understood. It hasn't been understood until really recently, until the last 12, 14 years, where the research starting to come out. But it's slow to make change. So I'd say that it's unfortunately it's not really fully accepted. And the other problem is that even when it's accepted, there's so much, there's discrepancy between the diagnostic criteria. And so not only are we dealing with a disease that is not well known, but maybe affecting at least 17% of the population, according to a study that was done in 2013, 2014 in Germany, where they showed that 17% of the population has mast cell activation syndrome. But there's a big spectrum, of course, not 17% of people that are sick, but it's a lot of people who have the potential to be sick. And so then you have these groups of physicians who have sort of split and are looking at this disorder differently. And so we have this consensus one group, we're calling them. They call themselves the consensus because they came out with the diagnostic criteria earlier on. And then there's our group, which is the consensus. We call ourselves the consensus two. And we're looking at diagnosing mast cell activation syndrome a little bit differently. And so I think that if you're not in one of these groups and you're like a doctor on the outside and you're looking at this, you're thinking, they probably don't know what they're talking about because they still haven't figured it out, And so that doesn't help. And really our goal is to really try to unify this, because the better we can diagnose people, the better we can treat them, the better it is for everybody, right?
Speaking of treatment, is there anything, obviously I've spoken on the channel previously about the importance of antihistamines and finding the right particular antihistamines that work for you, and how that helps almost everybody who's suffering with long COVID. But is there anything that women can do who are suffering this cyclical flare of their symptoms? Is there anything separate to just taking their daily antihistamines that they could do that would actually help them?
So I think the key is for them to figure out what is going to shut down their mast cell. There are women, and I would just argue patients in general, who don't respond to antihistamines. And I've seen this in men and women. For whatever reason, we've tried every one of them. But I will say sometimes you have to try 6 or 7 of them before you get to the 8th one, and you're like, oh, okay, And it's a little easier in the States. We have more options for antihistamines. But I think that it's very important that it's done systematically, that there's a trial and error process to sort of figure out what's going to work and what's not going to work. And so there's nothing specific. There's no drug that I can say, this is what I use for women during that part of the month. What I would say is, in general, women often need more control during that part of the month. I might have them on a regimen for their mast cells, but I know that they know they know the day that they're going to start to not feel well. So we may increase dosages. Sometimes it's as simple as that. Like, let's say they're taking loratadine twice a day. So maybe they take loratadine 3 times a day or 4 times a day during that time of the month. So that's one strategy. Sometimes we use hormones to control. So for instance, if a woman's estrogen, particularly in the perimenopausal period of their lives, some women have what's called estrogen dominance, meaning they're making a lot of estrogen. It goes up very high and it comes down really far. Those women feel better if you almost like give them a little estrogen and you just sort of suppress their big swings. So even though it's estrogen, it should theoretically be bad for their mast cells. It might actually help the swinging that's making the mast cells bad. So sometimes that's a possibility. And then any of the mast cell targeted therapies that we use could potentially be good. So it could be ketotifen, it could be cromolyn. Again, every person, every woman is different. Now, some women have more symptoms, let's say, related to bleeding, excessive bleeding, or dyspareunia, which is like pain during intercourse. So that's a little bit different. You can actually, we've published on this, actually. We have an article from, I think it was 2018 or 19, that looked at these different gynecologic conditions and ways that we attempted to treat them by a case review. Okay, so it's not like a study, but we had cases where, a patient was bleeding all month long and we couldn't regulate it and she's miserable. And she responded to just antihistamines. And it was pretty remarkable. Like within a week, she stopped bleeding. I mean, it was really like almost crazy. And I'll mention that the reason a lot of these women get bleeding as a problem is because mast cells make heparin, one of the mediators, and heparin is a blood thinner. So if they're making heparin, and they are, and the heparin is being released in the uterus, then they are, potentially going to bleed more. So if you control that, it could be something that you take systemically, or it could be something that you take intravaginally. So we've used different types of suppositories or douches or whatever, like locally, to just tell the mast cell, stop making the heparin, calm down and stop, right? So that's another strategy that some women need, is more like a topical approach to it. Sometimes it's, oral. So it's just about, honestly, I wish we could say, to your readers, oh, this is what I would try next. It's really so individual.
Absolutely. And this is a question that I don't know if you feel comfortable answering this one, but what are the challenges, generally speaking, facing women who experience chronic illness? And is there a gender bias in terms of treatments and the way that women are treated by the establishment generally when they present with chronic illness?
I always think that, again, I'm like an optimist, and I always assume like we're in the 21st century. Aren't we like beyond this already? We all talk about equality. And yet there's so much gender bias going on from the individual, on the individual level, but also just in terms of research that's being done and how they look at, let's say, even a drug trial in a woman, women versus men. Like it's really remarkable that it's really not, we're still not there yet, even in the science part of things. But yeah, a lot of the women, unfortunately, I would say that the majority of patients that I see have a story about something that happened to them from the medical community, from a doctor, from a nurse, for something. Everyone has a story, and that's trauma. That's medical trauma. This shapes how their body heals, how their mast cells react. Everything that happens to them is just going to, unfortunately, potentially make them worse. So it's really disheartening when this happens. But many of them are really, assume that they're making it up. They're exaggerating. They're histrionic. That term, histrionic, is an interesting term where how it, the evolution of that word. It's really sad. Men certainly get some of this. I think if you're chronically ill, period, you are going to have some bias against you, right? I don't know if you've experienced it, but I have male patients who say, their family members, other doctors just say, mind over matter, just push yourself and go to work. Men are just made to feel like you just push through, right? So it's a little bit different, but many men also suffer, women more. There is that assumption that women are potentially making things up. I don't know where it came from, but it's obviously the bias that gets carried through. And it's really a problem. And, it's about how do we change that? I think it comes down to medical education. And I think that the more people would understand mast cell activation syndrome, the better this would be. Because if you understood that the woman is complaining of, let's say, menstrual difficulties, right? And you understood that she didn't feel well during that part, but the labs didn't show anything crazy. But if you understood that there could be a mast cell component, or they have a lot of anxiety, and maybe the anxiety is worse during certain parts of the month, maybe it's not. But again, the assumption is always like, oh, they're just, they're stressed, they're depressed. And if they look back and say, wow, but the mast cells in the brain, when they're dysfunctional, if there's something that's driving it, well, then that's going to lead to anxiety and depression. I just think, like, when you use MCAS as a tool to understand patients, it just changes everything. But now it's getting the medical community to embrace it,
Yeah, I couldn't agree more. And it is a challenge, right? It's like, how do you change the perceptions of a whole culture, of a people, let alone a medical community, because that's how big it is. And it's the way that we look at women as a culture. And maybe we have moved on in the last 20, 30, 50 years, but I still think there's a long way to go. There really is a long way to go.
Yeah. And the more stories I hear from patients, the more I realize how long a ways we have to go. It's just mind blowing that the things like that I hear still happen,
Hope you found that interesting. Next up, I'll be talking to Dr. Sally Riggs about why a prior history of trauma and your personality type might put you at higher risk of developing long COVID. Till next time.